So I'll just start by introducing myself and Pavitra. I'm Shlesha Bagadia. I'm a psychiatrist and a psychotherapist and MBT supervisor for India, South Asia. Um, and Pavitra and me together, we co-founded the park, and we've been running it for a few years now. And we are um, we bring MBT training to India, and we've been very fortunate to have Professor Anthony Bateman uh, come quite regularly to do the training and adapt it to the Indian setting. So this is sitting somewhere in between our last year's training, where we had the cohort, yet another new cohort completing the basic, and we have upcoming advanced training and basic training this year as well. So we thought this is a good time for us to sort of get a sense of what's happening in the world of MBT. Just a few housekeeping rules as well. If you get logged out, you can message Pavitra. Pavitra, if you don't mind, you want to put your number on the chat. And please raise your hand or just let us know if you have a question to ask. Um, you can post your question whenever you want, but it would be nice if you keep your video on while you're asking the question. It becomes a little difficult to interact otherwise. And also tell us what your background is if you are currently practicing MBT when you post your question. Okay. So without further ado, I will get started. I am honored and delighted to welcome Professor Anthony Bateman, who needs no introduction, but I always have pleasure in introducing him. He's a professor, a consultant psychiatrist and psychotherapist, and the chief MBT coordinator at the Anna Freud. He developed a mentalization-based treatment along with Peter Fonagy, which essentially started off as a treatment for borderline personality disorder. But over the years, its adapted versions are used in several different situations, especially antisocial personality disorder, eating disorders, drug addiction. He's also been a part of the National Institute of Clinical Science, where they've developed treatment guidelines for borderline personality disorder in the UK and for eating disorders. Um, he's received several awards, and I won't go into details of that, but one of the things that's been really helpful for us is he's been very generous and open to all our weird and wonderful ideas of, bringing training to India. And we are really excited to invite him yet again in June for our next batch of the basic and advanced training. Um, what I would like to start by the session with is just to get an overview. So, Prof, if you can just give us a basic overview of MBT, and if someone who is just coming into this and knows a little bit about it, what would you like to tell them? And then we can get cracking in the rest of the question.
Thanks very much, Ashleisha and Pavitra and Apurva for inviting me to Park again, of course. And you're part of the Global MBT network, so that's something I'm, very happy to do. And welcome everybody, and thanks for joining. MBT goes back a long time, of course. It goes back 30 or more years in a way, and it arose in the context of the developmental research, really, with mothers, babies, infants, children, adolescents, and mentalizing. And it became apparent that mentalizing was a core sort of problem in mental health disorders. And we put forward the idea originally, which turns out to be really pretty correct, that mentalizing was the core problem in borderline personality disorder. In other words, it was the core dimensional psychological issue in personality disorder. And we therefore developed an intervention process that actually targeted the main symptom constellations of borderline personality disorder. So the main symptom constellations, of course, are relational, and that's really important in any personality disorder, but particularly is important in borderline personality disorder. and also the emotional management and self-soothing processes, which are problematic in the same condition, along with the impulsivity. But we also built MBT, therefore, to target their mentalizing so that it was actually all interventions were aimed to improve the strength, if you like, and the robustness of the individual's mentalizing. And treatment was a sort of semi-structured interventional process, and we based it in research. So we did a lot of feasibility work and a lot of looking at the interventions, and then we made it part of a randomized controlled trial. And that's where MBT has been cited throughout its development and implementation. It's always done as part of a research base. And we found that MBT was better than treatment as usual for the treatment of borderline personality disorder in all domains that were measured. So that was a good sign. However, to be fair, we were comparing MBT, which was structured, well implemented, part of a research program, with treatment as usual in the UK, which at that time was relatively random and really not well organized and so on. So eventually, MBT was compared for borderline personality disorder with a whole range of centers, really, and by independent researchers with much better and much better structured treatments, which were known to be more useful for people with borderline personality disorder. But our results were generally replicated by independent groups. Now, MBT itself was targeting borderline personality disorder, but mentalizing, of course, actually is a transdiagnostic mental process. So it can be applied to a whole range of mental health issues. So since then, it's been applied in a range of issues. So substance abuse, eating disorders, antisocial personality disorder, narcissistic personality disorder, and depression, and so on. And again, it's usually been implemented as part of research. So you can read all about that across the academic publications. Now, you might expect if mentalizing is part of mental health disorders, then it can be applied to a range of disorders. It does not mean, remember, that mentalizing is the core pathology of those disorders. Mentalizing may be disrupted, but it may be disrupted for all sorts of reasons. Whereas in personality function, we thought it was the core of the disorder, really. So we measured outcomes and so on, and it shows to be a evidence-based interventional process, particularly for personality disorder. And we also followed patients up. So we followed them up for 8 years, and that's the longest follow-up in adulthood of patients with a control group. And we found that the changes and improvements at the end of treatment continued across time for 8 years following randomization. So it's a robust intervention in that sense. So just briefly, what is it? It's a sort of semi-structured interventional process which continually targets the patient's mentalizing. And in doing so, it means the clinician has to, first of all, be aware of the patient's mentalizing. You have to be able to monitor it and monitor it reasonably accurately as how effective or ineffective it is. So we define very carefully for clinical purposes what ineffective mentalizing looks like, so the clinician can recognize it. And we then describe some interventional processes which actually will stimulate the return of mentalizing. And so on. Secondly, it is actually collaborative. So we do it in conjunction with the patient, with the client, so that they also are introduced to the framework through which we're all working together fundamentally. So we take first a particular structure to sessions. We secondly actually then implement certain interventions. First is the clinical stance. The clinical position is different from CBT and it's different from dynamic therapy. It's actually called the not knowing or mentalizing stance. And it's actually not knowing about mental states. So we interview, as it were, to generate a conversational partnership of to and fro between you and the patient, which actually facilitates mentalizing, which means we don't know about mental states. We can never know them of anyone, but we can kind of get indicators of them and so on, and get someone to express their mental processes in a way that the person expressing them feels accurately represent their inner states of mind. And then we have to show them that we can see those inner states of mind that they have. And that in itself will build a trusting relationship. And it's through that sort of trust in each other that you build mentalizing. You can actually solidify mentalizing, make it less vulnerable to being lost. Because the problem for most of our clients and patients is that they lose mentalizing when actually otherwise people would hold on to it generally. And when they've lost it, they actually feel tremendous psychological pain. And when they have psychological pain, they engage in all sorts of behaviors to try to feel better. And that's when they may self-harm, make suicide attempts, may be violent, maybe use drugs, and so on. And when that happens, of course, we've got to get them out as quickly as possible, because if they get stuck, which they do, we've got to help them so that they can recover quickly. Because losing mentalizing, we all have. We just mostly get out of it quite quickly. Okay, so they're caught. They lose it too quickly, they get stuck, and they can't get out. So that's what we target. We have to first use our stance. We then manage what we call mentalizing process, and we actually get them to explore their unmentalized narratives. So
Mm.
unmentalized narratives are things like the person comes and says, "Do you know what happened to me? I told my partner I'm never seeing them again, and I don't care about them anymore. I'm not keeping on with relationships." You get a narrative which is very often emotionally sort of stimulated and filled with strong driving emotion. Mentalizing will drop, and it particularly drops when it's in a relational process. That's what the sensitivity is. It's sensitive to attachment activation. And that happens biologically, it happens developmentally, and then happens to us all in adulthood as well. We lose our mentalizing more easily, really, with family, with partners, than we do with maybe professional colleagues who don't trigger our attachment processes and so on. So in MBT, we look very carefully at the attachment processes. So we define those at the beginning, we have a look at them, we sort of get the patient to have a look at them, and then we use those during treatment and across time. So it's this sort of structured process of working on mentalizing within the relationship with the patient. And we have a particular form of trying to turn unmentalized narratives, which could be trauma narratives, for example, into more mentalized narratives. Trauma, by definition, as a narrative, is generally unmentalized if it's producing symptoms. So
Mm.
complex PTSD or something like that is actually unmentalized trauma within our framework. So we need to convert that or help the patient change that across time to a mentalized trauma, and that actually reduces symptoms. So when we measure these things, we find that actually improving the mentalizing actually reduces their symptoms. Okay, and mentalizing is a very significant mediator of mental health symptoms. Okay, so improve the mentalizing, the symptoms will drop. And what we do is implement that in individual work and or group work across time. And normally we recommend a treatment length of around 9 months to 1 year, if possible. That's what the research suggests. For the more severe individuals, allows reasonably robust change that is maintained across time. Okay, so that's what we could have looked like overall. Have I summarized enough? I mean, I can always carry on talking for hours, so
Yeah.
I've got to be a bit careful. So
But we could listen to you for hours, Prof.
semi-structured treatment bring the patient into the framework with you. So we offer psychoeducation, in which you've developed in India as a cross-cultural sort of changes to that, and then use that psychoeducation to get the patient to become self-reflective, thinking about their own mental states. That is mentalizing, reflecting on myself, reflecting on self, and reflecting on other, which is a difference. Remember, mentalizing includes reflecting on other minds and other minds in relation to my mind. Okay, so the interaction between the two. Get them doing that, create the process to look at that, include within it the relationship they're having with the patient. That will build a level of what's called epistemic trust. That is the trust in the sort of knowledge and understanding that I can now rely on from this person I am sitting with and who is here to help me. And that allows change. Okay.
Thank you so much, Prof. That is, it's always refreshing to hear, no matter how many times I've heard it. I was just wondering, over the years, I'm guessing you've sort of gone and taught this in different places. Have has it developed, or you found different ways of talking about mentalizing as you're doing the training around, or are you finding people learning, like understanding mentalizing a lot better now? Or are you noticing anything different?
Yeah, I mean, it's a fascinating question. The first thing to remember, I think, is that what has become clear, and it's clear in research as well, is that mentalizing is universal in a way of human beings. So it's a human being phenomenon rather than a sort of country, a Western, Eastern, I don't know, Southern, Northern, anything else phenomenon. It's a human capacity, and it's in its complexity, it's a specific human capacity. In its simplicity, it's less so. So you get it in primates, for example, our nearest sort of ancestors and so on, and they show mentalizing, and you get it. You can actually have proxies of mentalizing in all sorts of different animal kingdoms as well. Um, uh, um, which are probably biologically driven. So, for example, in primates, the certain groups of primates, if they find, a lovely sort of coconut tree or whatever they eat, a mango tree, they want the mangoes and so on, they can do certain things. So they sort of realize that their whole group of them. So when I find my mangoes, I can make a call of a predator so that
Mm.
makes all the others run off, and they all run off, and I eat all my mangoes, so I get them all for myself. So I've got to have some sense, if I do this, that they will respond like that. So this is a sort of biological system that works. What they can't do with their mentalizing capacity in that sense is pop along to all the group and say, ha ha, I tricked you there, didn't I? Look, if you do this, you get all the mangoes for yourself. So they can't pop down the pub and explain, to the cafe, explain what to do to others. It just happens or it doesn't happen, and so on. Human beings can, they transfer this sort of knowledge and so on. So mentalizing is actually a human capacity, highly developed, allows us to function in large groups and so on. Now, what's fascinating, though, in a way, is that sort of implicit process of reading mind states of others and maybe misusing your understanding of reading mind states of others, or being empathic to mind states of others and so on, and being alongside them and supporting them and so on. That implicit functioning is, I think, universal. But remember, we actually make meaning out of understanding of mind states. So we take meaning out of that and actually, as it were, begin to represent the mind states. And that tends to be culturally determined. So how things are understood and what they actually mean, as it were, is this sort of explicit mentalizing, sort of making meaning and so on, is very different in different cultures, and we have to be very respectful of that. So, for example, we've done some work in Japan where culturally it's very distinct, and we have to get their reading of things. What is this? And they would suggest some things, and no, this is outside the norm. And I would think, well, looks okay to me, sort of thing, because I'm making meaning out of something, but they're making a very different meaning out of it. Um,
Mm.
so that's very important. And I think the same applies, as you discovered in India, to that sort of thing. These are culturally determined to a large extent, these components. And that's why MBT has to adapt, in a sense, for different groups of people. But fortunately, technically, since the main purposes of me as a clinician, let's say, is to understand the mind of the other person, I'd also, to do that, really have to try to spend time understanding their cultural values, for example. And I have to be neutral about making judgments about those cultural values. Otherwise, I won't see things from their perspective. Okay.
Mm.
Of course, it's harder for me to do as a sort of westernized, attachment related person. But, when I'm doing it in Eastern, West or South Asian culture or anything else, and locally, you're of course better at that because you're naturally able to do it. So adapting MBT is quite important, really, in different cultural value systems.
Yeah. Have you had sort of queries from trainees in different parts of the world that highlight this cultural difference or adaptability? Anything, like you said, Japan, for example, any other countries where language might be an issue? Because one of the things that I find is, how inquiry, even the curious stance, is structured in English, and most of the therapy right now happens in English, even in India, and we want
Right.
to make, when we start looking at using MBT in local language, it's quite a, I think Indians sort of inquiry is not only like it's very direct and very intrusive, and it's culturally accepted to be intrusive. So just being curious, and it seems very British, to be a little bit respectful and laid back. And so do you get, queries like that from other parts of the world
Yeah, we
where it's
do.
different?
Yeah, we do. Trying to sort of create the stance. But again, it brings up the issue that if your cultural value is that you would, in fact, be quite direct and quite sort of straight in there, then in a way for mentalizing, that's fine. What's not fine is for you to get in there and tell people what their mental state is,
Mhm.
even though you may be quite direct about or the way you ask questions or the way that you interact and so on. And we know that in certain cultures there are values about hierarchies. So the person sitting in front of you may be considered beneath you because simply because they're a woman or something, and these sorts of things are a problem, and so on, or that they happen to be a doctor and therefore they have to be treated in a certain way. There's lots of things that can start interfering, but absolutely, you simply modify, but you don't tell people about their mental states. They have to express them. In a sense, that's what you're trying to avoid rather than exactly how you do it. Um, but
Yeah.
it also happens in terms of our definition of ineffective mentalizing states. The one that causes the most problem I've discovered is pretend mode. We call it pretend mode, and as you're aware, and many of you may be aware, it's a terrible term in English, let alone translating it to another language. And so in Spanish, for example, there's two terms, and then there's arguments about whether it's more this term or that term because they differentiate between these states, and and so on. And you've got hold of sort of bubble mode and things like that because for people who are not aware, this mode of ineffective mentalizing that the clinician can look out for is when the patient really goes into their own world. Their mind is, as it were, retreats into itself, and you withdraw, say mentally, and you keep everything within your own world. And this is a big problem because then really nothing's coming in to help you change, or for you have to change through other people's minds to some extent, and the interaction between those minds, and it doesn't work in pretend mode. So defining that and actually naming it is a problem as well, because of how people see things. slightly differently. But interestingly, also, when I think something might, you said language, when I think something might, in the translation I'm getting from a translator, I think, oh, that's language that indicates ineffective mentalizing. They tell me it's not, or they pick something
Mm.
else up, which they say, no, 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 that indicates ineffective mentalizing for us. And then they have to explain to me why, because, whatever. But yeah, so those sorts of things can vary as well. Yeah.
Yeah, no, thank you for that. I can see that we have a couple of hands raised. Dr. V. Sai Kumar, do you want to ask us your question?
Thank you. Thank you very much. This is Dr. Sai Kumar from Chennai, and I am a full-time practitioner in counseling and psychotherapy and cognitive behavior therapy, working with individuals, children, families, couples, and others. And I have a great interest in psychotherapy casework and particularly adapting it to the Indian cultural setting. Okay. So, in fact, my PhD research also was related to that. My question related to MBT that you are talking about is that I find a lot of similarities between the concept of social cognition and MBT, and which talks about the kind of mental processes like perceiving, attending, remembering, and thinking about and making sense of the people that is who are involved in understanding of oneself as well as others. So, what way this is different from social cognition when it is already there? I just wanted to reflect on that.
Well, yeah, I mean, in a way, it's an interesting and academic question as well, because to a large extent, our argument is that social cognition, as called, as it's been around forever, is actually mentalizing, is the primary mental phenomenon that is underpinning social cognition. So the idea that, that it's actually remembering, repeating, and pushing and so on, these are sort of components of some aspects of social cognition. But we're saying, no, actually, social cognition is primarily due to the integration of mentalizing. That's what drives social cognitive processing. Okay, so we're arguing that that is the primary dimensional system that underpins it. And therefore, you target that. If you only target a component, say feeling interaction or expressive components or cognitive components or something like that, you'll miss a lot of the components of social cognitive, effective social cognitive interaction. So, targeted part of it if you like, but we're interested in targeting the whole processing system.
What about distortions that we traditionally talk about in CBT, cognitive distortions?
Yeah. Cognitive distortions require you in MBT to work out something is a distortion. Because a cognitive distortion, for example, who's defining that? Is that you or them
Yeah.
or both of you? And our stance would require you to work out if this is a distortion or not a distortion. And to do that, we don't use Socratic questioning, for example, because Socratic questioning is a sort of evidence-based appraisal assessment, and it's particularly ineffective in severe personality disorder. So, for example, Socratic questioning really, as a process of interviewing, actually creates more trouble for borderline personality disorder than help. Okay, they tend to self-harm more under the pressure of Socratic questioning. And so CBT for borderline personality disorder actually reduced the use of that CBT technique.
Okay.
Does some of that help?
Oh, yeah. Good. It's
Anyway,
good.
it's an interesting discussion of social cognition. But remember, social cognition is not just, it's a bit like theory of mind. Theory of mind is a cognitive appraisal system. And it was based in an experimental paradigm, really. And it's a small part of the overall social cognitive processing. It's very important, but it's a small part. And to a large extent, mentalizing took off from that it was around before, at the same time or before, but came through in terms of the overall social cognitive processing system, which requires much more. It requires an understanding of the other's mind, a dynamic monitoring of other people's mind, a subjective experience through other people's minds, a communication of feeling states of other minds, and so on. It's massively more.
Can we take it that the mentalization-based therapy derives strength also from the concept and theories of social cognition? Can we take it like that?
Yeah.
Thank you.
In fact, I remember, Prof, when I first attended the training, you sort of, you know, listed a lot of therapies that you derived from and
Yeah.
MBT is sort of developed from. But I think it's also, like you mentioned, it's a concept in itself quite complex and not, doesn't just involve one aspect of you know understanding core beliefs or understanding social cognition. It involves mind states as well, which is important. Not only
Yes.
yours, but others, which is quite
Yeah.
useful.
Yes,
But also,
mind states are not simply seen as core beliefs or schemas that are maladaptive and those sorts of things, or distorted cognitive processes and so on. That's it's a wider, yeah, understanding. You know, mental states have wishes, they have desires, they have a cultural driven beliefs beneath them, and so on. So there's a huge amount of in processing going into social interaction or social cognitive processing.
just an observation, Prof, also, what I've realized is that a lot of the other, like CBT or mindfulness-based therapy, the process of what happens in therapy is very similar to each other. But in mentalization-based treatment, you may understand what is mentalizing, what is non-mentalizing. But I think there is also a sort of a prescription of how the therapy is done to elicit mentalizing from the client in front of you. And that part of the process is also quite different compared to, and I've made the mistake, and I can see my supervisees make mistakes of, you know, telling the other person how to mentalize rather
Yes.
than enabling it through the therapy process. Um,
Yeah. Yeah, and in training, you're absolutely right. I call that MBT. Let me just give one or two distinctions. MBT, compared to other therapies, doesn't download so much into the mind of the patient. So we don't download, we don't tell them that is a distorted cognition. That is actually how you feel. This is actually what your, wishes are, and so on. So we don't give genetic interpretations like analytic dynamic therapy might give. This is downloading. We're trying to generate your mental processing within yourself to a large extent and trying to stabilize that and then improve it. So your self-reflective capacity, your level of curiosity about other people's mental states, your acceptance of doubt about other people's mental states and experience and so on, but living within that and so on, not insisting on things and these sorts of things. This is where we're targeted. So it is somewhat different from that, from the other thing. But as you rightly say, all psychotherapies share a huge amount of sort of similarity. They have a share a lot of overlaps in what they do and what sort of focus they tend to have.
Thank you for that. We have another question. Bhargav, do you want to ask the question?
I am Dr. Bhargav. I'm a psychiatrist. Prof, I was in fact the first batch of trainee from the park.
Yeah, I
Uh,
remember. I remember you. All right.
I've been doing MBT for last maybe since the beginning. So now I kind of moved
2019.
from India to Brisbane. I kind of live in Brisbane now. So I'm eagerly awaiting our supervisor training in June. So I think I have one kind of observation of having practiced MBT in India and also trying to practice it in my clinical setting here in Australia. So I think the one wonderful thing about MBT, which I find it really refreshing, is that it doesn't advocate to be an expert. So on people's mind, it is so refreshing, and that is kind of quite powerful with patients that sort of makes the patients feel like someone's looking at them, and that improves the rapport so much so that that itself is quite stabilizing for them over time. So that's just an observation that I have made over time, and people who struggled to engage. The change in approach has been so powerful for some of these patients. So that's just an observation, and even in Indian setting, though there is a cultural difference in your interaction, so this is actually quite powerful,
Mm-hmm.
uh, and it does work really well. It's been my experience. The second question I had is a very fundamental question. I always wonder when we talk about teleological mode and how and why people kind of gravitate to physical things in distress. I always fail to understand, Prof. Like, for example, when someone's so distressed, we talk about loss of self. Why do they have to resort to physical things to get out of it? So that's the thing I kind of couldn't understand. What's the fundamental principle behind it? Um,
Yeah. Well, your first observation is easier for me to answer than your second, which was a question. I'll try to come to it. But your first one, observation, I thought was interesting. And for people to just learn a little more about that, is that what you're really saying, your observation is that you've changed your stance in relation to the patient. So what you did is try to engage in your not knowing stance about mental states. Now, we imagined right at the very beginning that was quite easy for mental health professionals, but it turns out it's quite difficult because in a sense you're not going to be there then telling them what to do or give them solutions or tell them what the problem is and therefore you do this and so on. And actually that's really difficult not to do for all of us because we want to help our patients. So we want to say, oh look, well, maybe this is what you need to do and so on. So and in MBT we move from that. We say, well, we're not going to sort of tell you what to do. We need to work out with you so that we can generate with you a process that will lead to knowing how to manage all this. So we trying to focus on the process, getting you to do it. And that's what you're saying you've discovered actually turns out to be really quite helpful. And it's actually clinicians don't often think, oh, yeah, that'll be helpful. But when they do it and manage to do it skillfully, they suddenly think, oh, this seems to work. It's an odd thing. The patient feels seen. They feel actually they're beginning to understand how it is for me. Somebody's there with me. They become able to self-soothe at that point because they've got a relationship with someone. And that relationship is one in which I experience as a patient someone who sees it from my perspective. Everyone else was just seeing it in whatever way they did, but it wasn't my perspective. And it's really important that we try to get that in MBT. So you're obviously doing it skillfully, I would say, because you found it really significantly important with your patients. So that's great.
I don't know about that, Prof. The more you sit with your patients, the more you realize how
Yeah,
much you don't know.
yeah,
Don't
sure.
know. True.
But that's mentalizing. Then you know that you're mentalizing. Once you recognize that actually, the more I get through into this, the less I seem to know. Then you're mentalizing. That's great. The second one is an interesting question, which is when you actually lose your capacities to mentalize, i.e., you said teleological mode. For people who don't know, this is a terrible name for actually understanding meaning and mental states through behavior, through what happens in the physical world. So if somebody's late, they don't care. If somebody doesn't write the report on time, they've no interest in me, and so on. So everything's based on what happens. Okay. And what you're suggesting is that actually that's what patients do. And they engage in this ineffective mentalizing system that actually they engage in behaviors, they do things And the question is why? I think there's two possible kind of, we don't know why, but in a sense that I begin to experience an inability of representation. So I can no longer understand my own experience, represent it, contextualize it, mentalize it, soothe it, moderate it, manage it. And secondly, I have to be able to do that in order to express it to another mind. But if I can't represent it all in myself and therefore I can't express it, then another mind won't be able to understand it. And actually, in the mode and way of working, I'm like, if you like, a 4 or 5 year old mental state. So I actually kick and I do things to make you understand. In other words, I engage in a relative way of expression, which is, age appropriate when I'm 4, but not when I'm 40, if you see what I mean. Okay. So, in other words, I will get the other mind to see my problem, distress, whatever it is, but I can only do it through action. So we default to action in that sense. But exactly why the brain does that and the human does that, overall, but it definitely does it. you know but developmentally you can see that you don't have a chance of self-soothing when you're only 3.
Mm.
You do it a little bit, but not when you're overwhelmed by something. Your brain's not able to do it. It doesn't have the representational frontal lobe system capacity to actually manage the amygdala, the emotional uprising, that's the up regular thing, the upsurge that's occurring. So, it's not there. So what do we do with it? Okay.
I always also kind of I sometimes reflect that mental states are not tangible. So when we are
Enough.
distressed, our ability to form the tangible image is lost.
Yeah,
So as children, they don't in childhood, very young children, so they don't have the ability to form that image. So they need to have the reflected image from the parent or whoever is the
yeah,
caregiver.
yes,
So I
Yeah.
think they probably resort to something physical, which they could see. So it's something that I
that's
always
right.
reflect. It's a bit
Mm.
it just baffles me. So
Yeah,
that
and that's right. And the problem, of course, that's characteristic, isn't it, in the more insecure and disorganized attachment process. When they're activated, mentalizing drops, then you engage in behavior, and then you've got a problem because the response of the other mind actually isn't often helpful. So
yeah.
the response of the other mind is very often, stop it, shut up. How dare you speak to me like that? No, you're not going to go into hospital. No, this is not going to happen. Behave yourself. You're on the naughty step. And then everyone's surprised when the person goes, ah, and screams even louder because the
Mm.
response is actually, in a way, not in line with their experience of in themselves. So that's the problem. And that happens, of course, in personality disorder. They up the system.
Yeah, true.
It gets more and more sort of active. So it's not just the ambulance that are called, it's the police have to be called. And then when the police are called, they have to call the mental health services as well. And everyone's called. Okay. And the other option, of course, is to withdraw. So the other option is closing down. So you close your mind down so you're not reflective on the pain and so on. It's too much. So you close off. And the brain saves itself by closing down, like in severe trauma and so on. It closes down.
Thanks, Prof.
Thank you for that. Uh, Prof, can I ask you in terms of training? I mean, you conduct training all the time, all over the place, and you supervise a whole bunch of trainees as well. What are some of the common sort of mistakes MBT clinicians make? I mean, I can recognize a lot of them that, I can now understand their mistakes. But would you say some pitfalls or common mistakes that trainees make when they're trying to learn or implement MBT, and something that clinicians can keep in mind?
Yeah, I think one of the, well, I'm not sure they're mistakes. I think that what trainees often find difficult is not knowing about mental states. So this sort of acceptance in themselves of not being able to always accurately recognize mental states and to take that stance technically. So they find that very difficult. Trainees often go to problem solving very quickly and they give solutions very quickly. So they start downloading, if you like, very quickly and far too quickly. Sometimes have to download. I'm not saying we avoid it totally, but they do it far too quickly. And they don't get the exploration going enough in any way. That's one common mistake that they make. The second thing that they find quite problematic, but actually has improved a lot for some reason, which was we found when we were measuring, because we monitor sessions a lot, we have hundreds of recordings in research and all sorts of things. We asked them in training, don't join with ineffective mentalizing. So in other words, when a patient is ineffectively mentalizing, you tend to get drawn into it as a human being, and then secondly as a clinician as well, and you tend to start operating with ineffective mentalizing. Ineffective mentalizing in one person actually increases the likelihood of ineffective mentalizing in the other. And clinicians tend to early on get drawn into ineffective mentalizing, either not recognizing it or recognizing it and then arguing with it and doing things like that. And they get trapped. And once they're trapped, they don't know what to do. So that's the second thing they often find really problematic. We have to really work on that. And then, because basically non-mentalizing is infectious. And it's pretty infectious. So you have to keep out of it. And thirdly, they can find it quite problematic to actually create relational processes which actually involve them expressing their mind states, which is an essential step in MBT, expressing the clinician's state of mind in relation to the patient now in this context and so on, is really important for mentalizing each other. Okay, because I say to patients, there's two of us here, I have to try and work out and understand your mind and so on. And I said, but there's a sting in the tail. I want you to also work out, well, what's going on in Bateman's mind here? What on earth made him say that? So the patient can't say, well, a load of rubbish. You don't know what you're talking about. That's not an effective way of mentalizing my mind. But if they say to me something like, Bateman, I've no idea where you're getting that from. Tell me where that comes from in your mind. They're mentalizing my mind then. Then we're getting a conversational partnership. And it's quite difficult for therapists to actually regulate in a way the level of self-exposure and disclosure about their own mind states, like the counter-transference problem and so on, and things like this is a problem.
Thank you for that. I mean, definitely me, and I know a lot of my supervisees might feel relieved that it's a common problem that we're all experiencing. Apurva, do you have a follow-up on that?
A common problem.
I am feeling very relieved. So, thank you. My name is Apurva Shetty. I'm a clinical psychologist. I work with the Green Oak Initiative from Bangalore. So, Prof, I'm so thrilled to be sharing this space with you. I do have 3 questions that I wanted to ask you. Okay, so the first one is what you just talked about. So I definitely find myself more challenged, especially if it's confrontational from my client or even sometimes even withdrawal. But because I can feel myself slipping into a non-mentalizing stance. So my question would be, what's a way to perhaps decide mentalizing the relationship or mentalizing the transference, as it was previously called? What are your some thoughts about that?
Okay, yeah. So thanks for that. Yeah. So you're putting forward the clinical situation where, in a way, you're challenged by the client, where in whatever way, and so on. And you mean challenged in a large sense by the fact that your mind becomes sort of confused, as it were, problematic. You're not sure what to do or how to do it or something like that. And people often put that state of mind down to the fact that they're not experienced enough, or something like that. Well, this is most likely not the case at all. It's actually to do with the patient's mind that turns off or does something to your mind. So, how do we manage that in MBT is a really important question. The first is, of course, to recognize your own confusion or your own perplexity or the fact that you can't think. Very common that for clinicians, and it is a problem because clinicians always explain it on the basis they're not experienced enough to themselves. Your mind goes blank. Let's say the patient challenges you, does something, you don't know what to say. You think, I don't know what to say here. What would Bateman say? What would Ashleisha say? So someone else would know, but I don't. Oh, I'm not good enough. I'm not experienced enough. Probably got nothing much to do with that. Okay. It's actually because your mentalizing has been turned off, and it's really quite hard to effectively appraise your own mentalizing all the time as a clinician. We recognize others' ineffective mentalizing, but not necessarily our own. So one indicator of your own ineffective mentalizing is your mind going a bit blank, not knowing what to say. Okay, it's not down to experience. It's simply your mentalizing is turned off. Okay, so what does MBT do with that? Well, first of all, you name it, note it, you recognize it. Secondly, you actually tell the patient. Okay, that'll allow it to come back on. It's very interesting. If you say to the patient, don't just say, oh, my mind's gone blank. You might, but you're more likely to say, do you know, I can't think actually what to say to that. My mind's slightly gone off here. I'm not quite sure why. And you do your mentalizing return in front of the patient. So you model the return of mentalizing. How do you get it back? You get it back by self-talk in general. Okay. And the patient might want to interrupt you because they're being challenged. No, 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 hold on. Just let me get my mind back here because I realized that when you were talking about this, and then rewind yourself and bring yourself forward a little bit in whatever conversation you've been having, it will bring your mind back on. And I can give you hundreds of examples. So always let the patient know they've blocked you here somewhere, or your mind is blocked, but you think it's something to do with what's going on, and then rewind and move it forward. Second, when you're really under fire, they're just going at you. And that can happen when they become emotionally dysregulated or they feel in such pain they don't know what to do with it. And as we were talking, they become behavioral almost and so on. Again, you can let them know a little bit that how difficult it is when it's like this, that for you to think really and to think clearly in order to help and so on. You can do that. But the second thing that you can try to do in MBT is actually just hold on to the fact that this is what I call noise. And I call it noise because it's all the noise because you're not understanding how they experience themselves. Do you see what I mean? They feel alone. So I always say, look, avoid the noise when it's all happening if you can. Don't get caught with it. Seek the pain. Okay? Take responsibility, though, for the creation of that pain in the session if it's happening in the session. So the way we do that is say, look, you're saying and shouting all these things at me at the moment. That's really disturbing my mind a little bit and so on. But actually, I'm trying to get hold of something that I realize I'm not picking up. What's so difficult? Do you sort of mean? You take, again, responsibility for not quite picking up the level of pain in some way.
It's very helpful.
Is that all right?
Yeah,
Yeah.
absolutely. Yeah.
Thank you so much. Do you have more questions, Apurva? I'm
I
gonna
can come
just,
back.
I'm mindful of the time. Yeah.
Yeah.
Because I do want us to just focus a little bit on what's coming up and what's sort of happening in the world of MBT. And then if there is time, we'll see if we can get to all of your questions. So, Prof, Can you tell us a little bit about what's new and upcoming in the world of MBT, and what's been happening in both in terms of training and clinical practice?
Well, I'll be very brief because we haven't got long. We left an hour, so um, I'll be very brief. I mean, what's coming up and what's been going on? We've been looking at, as many of you will know, the intervention and treatment process of people with antisocial behavior, antisocial personality, and particularly violence, which we think is mentalizing, ineffective mentalizing driven to a large extent. So we've been looking at that, and we've published a lot of data on that. So randomized controlled trial of antisocial and so on. So that's been going on. That's in Lancet Psychiatry in last February, March time, I think. We also developed research projects on modules specific for mentalizing and trauma. So people with complex PTSD who look like severe borderline personality disorder, in other words, with self-disorder, organization problems, impulsivity, emotional regulation problems, but also symptoms of PTSD, flashbacks and vigilance and withdrawal or avoidance and so on. So with that group of people, and we have a trial now with a manual for the MBT clinician to try to working on that. And there's attempts beginning to look at in much more detail interventions in autistic spectrum disorder, but that's sort of relatively early stage currently. And again, you can see why mentalizing might be a core issue. And is already seen by certain people who've done a lot of work on severe autism and so on and mentalizing. But we're talking here about the more social cognitive sort of difficulty end that used to be somewhere in Asperger's syndrome, but at the end, the other more moderate, mild to moderate end of autistic spectrum disorder. We're looking at that. Um, anyway, I'm sure there's plenty of other things, but yeah.
Well, I can remind you what you've been telling me. In terms of training, I think you're also sort of now you have a curriculum for MBT group, which
Yeah,
is
we do, yeah.
in addition to the individual MBT, and also a lot of training of allied professionals and
Yeah,
other professionals on just understanding mentalizing and getting some skills in picking up non-mentalizing. So
yeah, we do, yeah. And we're just doing that. That is adapted. I was doing it this morning and then I had to break my concentration. Oh gosh, I've got to speak at 11 o'clock to you with you. I had 2 hours this morning trying to generate that skills program really for prison officers and people involved in that sort of system. And we also have a protocol developing for emergency work, people involved in high risk, high emotionally situations like emergency departments and so on. And that's the skills program. Absolutely, we do. Yeah.
I mean, I think that's really fascinating because one of our main challenges is not just working with the person with the disorder, but the system they're surrounded by who also have very little understanding of mentalizing and what's
Mm.
happening with the mind states of the person affected. And I didn't know we kind of almost like they are out of time. Bhargav, your hand is raised, so I don't know if you have quickly
Prof,
question. And I
is
know,
the manual for complex PTSD, the trauma, is that available at all by any chance for us to
Yeah.
have a look at?
Y- just at the moment, the answer to that is no. I'm sorry. We usually share all our materials, but it's currently under research. So the groups are being recorded, and we've done 5 groups as feasibility, but this is now part of the trial. So they're being recorded, and we'll change the manual probably, at certain points in over the next, say, 6 months, because we're doing it in a number of centres, rather than just ordinary research centres, as it were, specialist centres. These are general mental health centres. So we may have to tweak it, change it, and remove some things. So we're not distributing it at the moment. It's only for those centres doing the research, running groups for the research. But hopefully, in 6 months' time, we will have, say, yeah, this is fine or not fine. Okay. So sorry about that. It's a very interesting program, I should tell you. I'm not trying to, sorry to, that's a bit unfair, isn't it? Stimulate your interest and then say, well, you can't have it anyway. Sorry.
Well, we
I
look forward to when we
don't
can
mean
have
to
it
do
because
that.
I'm
Yeah.
sure it'll be very,
Yeah.
very helpful.
Yeah.
Thank you so much, Prof. I'll just, quickly talk about our training. Maybe I'll hand over to Pavitra. Um, and if people have any questions, you can still post them in the chat. We'll see if we can send you email responses back because we are out of time for today. Pavitra, over to you regarding our upcoming training.
Right. So Professor Bateman's going to be in India in June, both for the basic training and the advanced training. I've just posted the flyer in the chat. We'll also email them to you. So please take a look. A couple of things I just wanted to point out. A part of the training is an introductory course, which is self-paced. That's conducted by Ashlesha, which is mandatory as a part of the course. If you're unsure about going ahead with MBT, what you can do is try the introductory course. We'll give you a coupon code because you've attended this session, so you can have a 15% discount on the self-paced course. The cost of the self-paced course will be adjusted if you sign up for the MBT basic training with Professor Bateman. So 15% discount if you sign up right now. And also the cost of the introductory course will be adjusted against the basic training course. So that's the basic training. We see a lot of people who've been in the basic training. Advanced training can also be signed up for in right now on the web page. You can just look at the flyer, click on the link, you'll go to the MBT South Asia page and you'll find all the details. If you have any queries, you can text me on the number that I've put in the chat, or you can email us. We're very quick to respond.
Thank you,
Back
Pavitra.
to you.
And thank you so much, Prof. I don't know if you have anything else to say as a final closing statement before we end the webinar.
No, I mean just to say that all these different forms of MBT or the different conditions it's being used for follow the same principles of the core basic MBT. That's what the training that you're offering is about, and then it's adapted slightly depending on the target population. So just to finalize the question around trauma, of course, then really, as I mentioned, trauma is characterized and appraised as unmentalized personal narrative. So I have a history of attachment trauma or other trauma, and actually it's unmentalized, so it's unprocessed, and so on, and therefore it pushes forward. I get memory, I get return of memories, I get flashbacks, I get stimulated, I get triggered, and so on, because it's unmentalized. So again, the process is organized to actually mentalize that narrative. So it follows the same principles fundamentally. So the manual, of course, specifies how to do that. But basically, the core MBT basic training is the thing that's becomes skilled at first, and then you start targeting. So, but I'm very grateful for people's interest, really. I mean, it just happens to be my area of interest, but it's always nice that other people are interested too. So thank you for joining.
Thank you so much, Prof. We really look forward to seeing you in June. Bhargav, did you have another question? Or
Just a
do you want to
question
cover
about signing in for the supervisor. I mean, is it the advanced training or what do we have to do?
Yes, you have to do the sign up for the advanced, and you will have a small module which is part of the supervisor training. So you come for the advanced and get that as a refresher, and then there'll be a separate supervisor module for you as part of that.
Sure. So that's the one we have to sign up for, the
You have to
advanced.
sign up for the advanced. And the training will be in Bangalore. We'll let you know more details in terms of venue and everything once you sign up, but do reach out to us for any other queries. For all of you who are in basic training and have or completed basic training and still are not sure, just let us know if you're interested in signing for the advanced training. Yes, Pavitra?
I also forgot that we have a learning grant for 2 seats.
Yes.
So if you do want a learning grant, please do email us and we'll send you a form. There's a process. We'll send you a form to apply for it.
Wonderful. Thank you so much, everyone. Thank you for joining. And thank you so much, Professor. I hope you can go back to doing the draft so that we have access to it soon. Thank you, everyone, and have a good day.
Thank you.
Okay. Thank you, everybody. Bye.
Bye.
Bye.